So all of you know tuberculosis. So what are the causative organisms? One is Mycobacterium tuberculosis. Other than that, another one I told you, NTM. What is NTM? Non-tubercular mycobacterias, and that also we classify them again in photochromogens, cotochromogen, non-photochromogens and rapid growers, yes, according to their growth. Next, what is the mode of transmission? Primary mode of transmission, droplet through airborne, isn't it? Then next, what do we do for our lab diagnosis? First thing first, Ziehl-Neelsen, yes. In Ziehl-Neelsen, how do you describe the bacilli? It is long, slender, beaded, red color, slightly curved bacilli. Other than that, one modification of Ziehl-Neelsen, what is that? Cold method. What was it? Otherwise called as cold method? Kignon's method. Then next, another fluorescent staining. With fluorescence microscopy we do. What this thing stain do we use for this? Auramine. Okay, so in staining, which one is more sensitive? Here the regular Ziehl-Neelsen, which we focus under the light microscope, or the fluorescence? Which one is very good? Okay, you remember this fluorescence, how do we see? Background is dark. And against the dark background, what do we see? Green colored bacilli will appear against the dark background, and that is your Ziehl-Neelsen, yes? Then next, what is this? NTEP grading. What is the full form of NTEP? National Tuberculosis Elimination Program. Very good. This grading is done for which sample? Only sputum sample. Okay. Why do we do this? One is to monitor the patient once the treatment has started. Another thing, to know how much is the severe the disease the patient has and whether the patient is responding to the treatment or not, and the infectiousness of the patient. Next goes to the culture. In culture, two things we do. One is your conventional technique, another one is what technique? One is conventional, another one is automation. So in general, anyways, in any conventional method, it takes little bit longer, the turnaround time. So for this, generally the turnaround time for your conventional is 6 to 8 weeks, okay? And for automation, it is 3 to 4 weeks, little bit earlier, okay? So for your this conventional, what media do we use? Laustin-Jensen media. What is the type of colony you see? Rough, tough and buff colonies. Very good. And in your automation, what do we do? Midget Mycobacteria growth indicator tube. Okay, fluorescence color will be formed if there is any growth, isn't it? So another thing we do in midget is we test for ATDs. What is ATD? Anti-tubercular drug susceptibility. Okay. Then another thing we do is LPA. Line probe assay. What do we do in line probe assay? We look for first line and second line of ATDs, whether it is susceptible or resistant. Okay. Then next, once the growth is there in the Laustin-Jensen media, we have to further identify whether it is Mycobacterium tuberculosis or NTM. How do we do next? We take the colony, we put it in the MALDI and it will identify. Another thing we do is, I told you, MPT64 antigen detection by, what is the methodology? What is ICT? Immunochromatography test. If MPT64 is positive, what does it indicate? MPT64 is positive? No. It is for identification. It is Mycobacterium tuberculosis. Okay. Then next goes the molecular. Molecular PCR, I told you PCR always we target certain gene. So here what do we target is IS6110 gene. Okay. Other than that we do NAT. What is the full form of NAT? NAT. Last class also I told you. NAAT. No national. Nucleic acid amplification test. There we can do a CBNet, that is cartridge based nucleic acid amplification test. Another one is TrueNat. Okay, I told you about line probe assay. This is how the cartridge looks like. Okay, this is CBNet. Okay, another thing, last but not the least, we diagnose for latent tuberculosis. First is tuberculin skin test, otherwise called as Mantoux. Mantoux, what kind of hypersensitivity is it? Very good. Otherwise called as delayed hypersensitivity. Another one is IGRA. interferon gamma release assay. So if somebody is positive for your Mantoux or IGRA, do you think the person is infected with tuberculosis? If we all test, 80 to 90% of us, we will be IGRA positive or Mantoux positive. Does it mean we are infected? We are exposed to the organism. That's why we will come as positive. Right? So March 24, it is celebrated as World Tuberculosis Day. Okay? That's it from my side. Okay? Thank you.
Consider tuberculosis not just as an infectious disease, but as a major public health concern. To consider tuberculosis just not an infectious disease, but as a major public health concern, particularly in countries like India where the burden remains significantly high. So we can see there is a global challenge that TB remains as a top 10 cause of death worldwide, and India's burden is almost about 27%. So most common form, pulmonary TB, is the most infectious presentation, and our key goal should be early diagnosis plus treatment and breaking the transmission chain. So as introduction to that, TB is caused by Mycobacterium tuberculosis, primarily affecting the lungs. It is transmitted via airborne droplets and disproportionately affecting the economically productive age group. And there are many more associations to the TB, and many more challenges are also there, as there is delayed diagnosis, sustained community transmission, long duration multi-drug therapy, and the emergence of MDR and XDR-TB. So as a case scenario, we are going to present one. A case represents typical patient presenting in outpatient settings in India. A 35-year-old male belonging to lower socioeconomic group presents with a chronic cough lasting more than 3 weeks. This duration itself is a red flag for tuberculosis. In addition, he has constitutional symptoms such as fever, weight loss, loss of appetite, and occasional hemoptysis, and also associated with fatigue, generalized weakness, night sweats, and there is no prior history of TB treatment. So chronic respiratory symptoms and constitutional features strong clinical suspicions for pulmonary tuberculosis. Clinical features of pulmonary tuberculosis for respiratory symptoms such as persistent cough more than 2 weeks. Most common symptoms: sputum production plus minus purulent, hemoptysis, and there might be chest pain, which is mostly pleuritic in some cases. Fever, constitutional symptoms like fever, classical will be the evening rise fever, and progressive weight loss and anorexia. The patient will not know he is having weight loss. Night sweats, fatigue, reduced work capacity. So our patient has chronic cough, evening fever, weight loss, hemoptysis, classical presentation for pulmonary TB. Risk factors and epidemiology, and among host factors, HIV is the strongest risk factor in India. And in India, conditions like malnutrition and diabetes mellitus are equally important contributors. Smoking also plays a major role by damaging lung defenses. Environmental factors such as overcrowding and poor ventilation significantly increases transmission. This is why TB is more common in slum areas, prisons, and densely populated regions. Another key point is close contact with active TB patients, which greatly increases the risk of infection. In our case, the patient smoking history and low socioeconomic status place him in a high-risk category, further strengthening our suspicion of pulmonary tuberculosis. So we need to approach the patient systemically once they present to the outpatient department. The first step is the detailed history, focusing on the duration of the cough, fever pattern, weight loss, any history of TB exposure, or any diabetes, HIV, malnutritive patients, what is their socioeconomic status and all. Next comes physical examination. Although findings may not always be very specific, signs like crepitations in upper lobes or bronchial breath sounds can suggest pulmonary involvement. So, according to NTEP guidelines, any patients with cough lasting more than 2 weeks, with or without constitutional symptoms, should be labeled as presumptive TB case and investigated further. And equally important is the infection control. Since TB spreads via airborne droplets, simple measures like a mask can significantly reduce transmission. In our case, the patient clearly meets the criteria for presumptive TB and should undergo diagnostic evaluation immediately. We need to understand that sputum examination is the cornerstone of pulmonary tuberculosis diagnosis. Sputum smears microscopy is usually the first investigation performed. It detects acid-fast bacilli using staining techniques like Latent staining. 2 samples are collected. So here we can see the first line investigations as sputum examination, then we can go for CBNet, TrueNat, and advanced tools like culture, which is a gold standard but time consuming, and we can also do line probe assay, CT scan for complicated cases, and chest X-ray for supportive, but not confirmatory. Microbiological confirmation is mandatory whenever possible. So for the sputum smear microscopy, usually it is the first investigation performed. It detects acid-fast bacilli using staining techniques like Latent staining. 2 samples are typically collected, 1 spot sample and 1 early morning sample. The main advantages of this method, it is simple and cost effective, making it ideal for the large scale screening in those resource limited settings. However, it has limitations. It cannot detect drug resistance and can miss many cases with low bacterial load, especially in immunocompromised patients. Culture is considered the gold standard, but it's very lengthy process. So we can also do CBNet, which can detect TB DNA, rifampicin resistance simultaneously, and it can give the result within 2 hours. And we can also do TrueNat, which is a portable battery operated, especially it is ideal for the primary healthcare centers. So, role of chest X-ray, supportive investigation but not confirmatory, help assess the site, extent and complication of the disease. Mostly the upper lobe infiltrates is the most common, and cavity lesions is the hallmark of the active TB. Concentration fibrosis can also happen. in later stages. So for the first line treatment of pulmonary TB, we can, in intensive phase for the 2 months, we can give HRZE regimen, which is H for isoniazid, R for rifampicin, Z for ethambutol, Z for pyrazinamide, and E for ethambutol. Then continuation phase for 4 months, HRE, isoniazid, rifampicin, and ethambutol. So we like to give it in, it's a guideline for the fixed dose combination, which is weight-based combined tablets, which improves the compliance and reduce pill burden and prevents misuse and resistance. So weight-based FDC dosing are here as I have listed. Less than 25 kg, we can give 2 tablets. 25 to 39 kgs, 3 tablets, like that. 40 to 54, 4 tablets. 55 to 69 kgs, 5 tablets, and more than 70 kgs, those 6 tablets. It's a combination of all these drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. We can do the dosing like that. We can remember like 5, 10, 25, and 15. 5 for isoniazid, 1 per kg as per body weight for isoniazid, and for rifampicin 10 mg per kg body weight, for pyrazinamide 25 mg per kg body weight, and for ethambutol 15 to 20. Mostly we do 15 mg per kg. These are the second line drugs. So there is something like drug resistant TB, and there is MDR-TB, multi-drug resistant TB, which is resistant to isoniazid and rifampicin, and XDR-TB, which is MDR, multi-drug resistance, means rifampicin and isoniazid plus resistance to fluoroquinolones and other second line drugs. What are the causes? Incomplete or irregular treatment, wrong drug combinations, poor adherence, inadequate dosing. So for diagnosis, we can do CBNet, which will detect rifampicin resistance, line probe assay, culture, like that. So we have, there is a new regimen which has been started from 2025, known as B-Palm regimen, which is bedaquiline, B for bedaquiline, P for pretomanic, L for linezolid, and M for moxifloxacin, which is a shorter regimen, mostly given for XDR-TB. Duration is for 6 months, which is fully oral, better outcome. Complications of pulmonary tuberculosis in respiratory, like hemoptysis, pneumothorax, pleural effusion, respiratory failure, bronchiectasis. Extra-pulmonary spread can be happen, miliary TB, TB meningitis, pericarditis, spinal TB, which is known as Pott's disease. Structural damage and systemic manifestation can happen. Public health perspective and NTEP suggests early diagnosis, proper treatment, contact tracing, and TB elimination goal. For summary, clinical recognition: cough more than 2 weeks, plus fever, plus weight loss, plus hemoptysis, high suspicion in endemic areas like India. Diagnosis: CBNet, TrueNat first line test after sputum test, always confirm microbiologically, assess rifampicin resistance. Management start early HRZE, then HRE regimen. Strict adherence is non-negotiable to prevent drug resistance. And rising global concern for drug resistance TB, we should be aware of that. So think TB in every chronic cough. This is the message. Thank you.
Discuss, I've seen microbiology, their diagnosis and everything. Now in medicine, they are able to discuss some clinical features. But pediatric TB is little different. Because there is a paucity of bacilli. For diagnosis is very difficult. Confirmed diagnosis is very difficult. Then that's why we face a lot of problem in pediatrics. Still we believe in confirmed diagnosis, probable diagnosis, suspected TB. To confirm TB, probable TB or suspected TB. Now we'll go a little bit while discussing this. Next slide. Suppose a case has come with 2-year patient, old child, low grade fever for 3 weeks, cough for 2 weeks, history of not gaining weight, history of contact with grandmother who is on treatment for pulmonary TB. Why? The pediatric patient, they usually get their infection. How TB is spread? It is an aerosol spread, means airborne disease. Now, in pediatrics, as there is a paucity of bacilli, chance of spread from pediatric patient is less than the adult. But it is not absent, I won't tell. That from pediatric patient TB will not spread, I will not tell. 8-9 years boy can spread the TB. He may have cavity also. So, but his grandmother, who is possibility of more bacterial load, so she can spread. So she had a contact with TB. So this patient has come with fever, and fever without focus for long period. Tuberculosis is also one of the causes. We should always keep in mind, not only TB, there are so many causes we can think, but TB also we should keep in our mind. That's why we should take history of cough, these things there or not, family contact history is there or not. That history you should take. Next slide, please. Next slide. Oh, check. The persistent fever without known cause, unwilling cough for 2 weeks, weight loss or not gaining weight for 3 months with good diet, with or without contact with patient with pulmonary TB in the past 2 years. Extra-Pulmonary TB clinical features. This pulmonary TB will have cough, fever, weight loss, these histories we will get. Even sometimes we get a history of hemoptysis also. But extra-pulmonary TB can affect how before going this, I think this is covered, how TB spreads in the body. How? So, aerosol, it goes inside lung, isn't it? Then how? By macrophage it goes to lymph node. From lymph node, there is that lymph node will enlarge, pulmonary primary complex, PPC. Then if this host immune mechanism is good, then this infection may abort. But we may get later calcification. But if the immune response is bad, then there is a progressive pulmonary disease can be developed, PPD. So the KGS, glowed, hematogenous spread, this thing, miliary tuberculosis, everything I think discussed in pathology, so I am not going to detail all these things. So if goes spreads in the lymph blood, then you can go to lymph node, painless, firm neck gland you may get inguinal gland, you may get abdominal also, you can get anywhere, you can get lymph node. TB meningitis also can, second most important, extra pulmonary TB. Then miliary TB, you will get hepatosplenomegaly, persistent fever, respiratory distress, bone TB. Bone TB, another most common, bone TB, tubercular, arthritis. So many things can occur. TB can spread through blood, hematogenous spread. How hematogenous spread occurs? How hematogenous spread occurs? Anybody? Hematogenous spread, how it occurs? If this caseous gland breaks in the artery, it can spread through the whole body. If the caseous gland breaks in the bronchial lumen, it can call endobronchial tuberculosis. Endobronchial tuberculosis may have wheeze, cyanosis, severe respiratory distress. Then the patient will come with wheeze. We may think of asthma. So if asthma doesn't respond with usual drug, we should always keep in our mind whether is it some endobronchial tuberculosis. It may lead to the bronchiectasis. So many things may happen in endobronchial tuberculosis. Then miliary tuberculosis, if it spreads in the blood vessel caseous gland, then whole broad body will be affected. Then he will have high fever, he will have loss of appetite, respiratory distress, cough. Chest you may not get any findings. Mild cracks may be there. If you see the fundus, you will get tubercle. If you see the fundus. So it should be cautious of biliary tuberculosis. Then there may be hyperosmolality. Tubercular meningitis, it is a chronic meningitis. Patient will have high fever, headache. Initially, he may be little unaware of his lethargy. Then ultimately he may have a coma, unconscious, convulsion may be there, so many things. If you do LP, lumbar puncture, this will give you the answer. Everybody will tell earlier CT scan, before that you should do a lumbar puncture. If you do lumbar puncture, you will get the answer. What is it tubercular meningitis or pyogenic meningitis? There is a difference because high protein, low sugar, then cells mostly lymphocyte, and it is so much high protein that you will get, if you see physically, you will get cobweb, physical examination. If you keep some time, you will find this some sediments, cobweb is there, formation is there. Then you do microbiological test, confirmatory. Nowadays we are doing PCR, TB PCR also we are doing. I am not going detail on this CF examination. So all these things you should do. So TB meningitis, CSF examination is most important. CSF examination may, what you see, we see physical, then biochemical, then cytological, means lymphocyte is more, then microbiological test you should do. Same in this, you have X-ray chest shows right-sided hilar and paratracheal. In children, what I told you initially, there is a bioaerosol goes to the lung, then macrophage goes to the lymph node. So there is a lymphoid gland enlargement will be there because microorganism grows there. Gland में cageation भी होता है. So you know this cageation. So these X-rays show right-sided hilar and paratracheal lymph node. See, this is paratracheal lymph node, this is hilar lymph node, enlargement. In primary focus, you may get some parenchymal lesion. Here we are not seeing any parenchymal lesion. Primary focus, sometimes we get parenchymal lesions, but majority time we don't get parenchymal lesion. We see only lymphadenopathy, some enlargement of lymph node. That is in primary complex. Then, for confirmation, this gives clue. Suppose the baby boy, he has 2 years boy, he is having history of contact with TB, he has come with this finding. Then we will always suspect TB because there is a gland enlargement is there. For confirmation, what we do, we try to do gastric aspirate examination. How gastric aspirate is taken? Gastric aspirate is taken early morning before baby gets up from the bed. Why we want to take early morning? Because whatever respiratory secretion he has swallowed, before the peristalsis empties the stomach, it will be available, it will be in the stomach. So if you do early morning, before gets up, wake up, we take the sample, gastric ET tube, you take the gastric sample, at least consecutive 2 days you take gastric sample, because the adult, they can expectorate. So for them, there is a problem, to get sample is easy. For children, we always advise to take gastric aspirate. So we can take this. Another is, we can take aspirate 4 to 6 hours fasting. That also this is an outdoor patient. In outdoor basis, we can take gastric aspirate in this way also. Then another way of taking sample is induced sputum. Induced sputum is there. We can induce sputum, especially little bigger boy, the children we can do. How we can induce? we can induce sputum by, first we nebulize with salbutamol, then 3 to 5% normal saline. It will induce an expert hand, they can, from nasopharynx, they can collect the nasopharynx secretion, they can collect by aspiration. So that is called induced sputum. So X-ray chest, giving indirect evidence. For confirmation, we will go for gastric aspirate for diagnosis. Again, for the confirmation diagnosis, we can do culture. Nowadays, we don't do. Culture medium, LG medium, we don't use because it takes long time. Nearing 2 weeks, nearing 7 weeks, I think, 7 to 8 weeks time, isn't it?
Yes, ma'am. See, students, this is very important. Tuberculosis can be asked to you in any level. Go to medicine department, go to microbiology, go to pathology. So this is a very important chapter. So we have kept this integration class, so it is informative to you. You are getting in this platform, you are listening to the pediatrician who is talking about the baby who cannot put out, he cannot aspirate his sputum, right? So when we ask you what sample you take from a 5-year-old child, you have to be able to answer. He has already given those. So these integration classes are very informative. You have to listen to these classes very minutely. So don't just think that you are attending and going back. So if you listen to the classes, you will be definitely helpful and you can answer the questions. Okay? So please maintain silence and listen to it properly. All of you.
So the culture, usual culture, earlier we used to, when we were students, we knew the LG media, Fluorescence Johnson media. Nowadays we are having some other backtech media we can use. We can use MGIT, microbacterial growth in induction tube. MGIT we can use culture. We can do culture in this way, where we get report within 2 weeks. We along with the sensitivity pattern. What drugs it is sensitive, because Sir has told earlier, the multi-drug resistant TB is there. So we can get the sensitivity pattern also with this culture. So after doing this for confirmation, we can see by, earlier we used to see under microscope by staining, gel staining. Staining. Now we can do CBNet. By 2 hours, we will get the diagnosis and resistance pattern, rifampicin resistance or not. And if rifampicin resistance is there, we always assume that it will be isoniazid resistant or sensitive. If it is sensitive, it is very good. It will usually we use first line drugs. If it is resistant, we have to go think some other drugs we have to give. So gastric aspirate for CBNet. But for this baby, it was negative. Mantoux was 12 millimeters. What's the Mantoux test? I think I'll show you later. ESR is highly elevated. In this microbiological confirmed, it is not microbiology confirmed now. Now this TB, evidence is there. History suggestive, X-ray suggestive, because cardiac lymph node is there. But still microbiological confirmation nahi hua isme. That I have to. So for diagnostic Pulmonary TB, first we do a X-ray. If there is history suggestive of tuberculosis, we go for X-ray test. X-ray is highly suggestive of TB. Expected, that's I told you, expert sputum induced or sputum or gastric lavage. For anybody approved NAT for multiple tuberculosis. If it is positive, we start microbiology. If it is a positive, then we will go for, because here CBNet is negative. So it is not positive, it is negative. It is negative. If it is a positive, then we go microbiology confirmed TB. If it is a confirmed, I told you it is a rifampicin sensitive, or CBNet will give you diagnosis rifampicin sensitive or resistant. If it is a rifampicin sensitive, we will go for first line therapy. If it is a rifampicin resistant, we will go for second line drugs. Second line drugs we will tell later. Second line drugs. If negative, we will do some more evaluation. If some glands are available, some neck glands are there, some superficial glands are there. We can do FNSC, we can do lymph node biopsy, any tubercular granuloma is there or not, we can see. FNSC, we can take tissue. That tissue also we can do for culture. Then if lung is there, we can do bronchoscopy, we can do bronchoalveolar. Earlier we have done induced sputum or gastric aspirate. Now we are doing BAL, bronchoalveolar lavage. We can do bronchoscopy and BAL negative. We want to confirm the diagnosis. We can take BAL for our culture and CBNet, everything, all test for culture and microbiological confirmations we can do. So we can, if it is negative, if you want to confirm that the case, if facilities are there, we'll think in that line. If negative, CX are negative, but evidence is there, suggestive, then we suspect may replace CACT test or other investigation. We can repeat it or consider to refer to higher center for proper evaluation. All TB cases we should go for HIV test. All TB cases we should do HIV test. So here we can have suspect case. We can suspect. Okay? So this is the guideline. That means first you do X-ray. X-ray is of TB. You go for bacteriological confirmation. How you do bacterial confirmation? We take sample. We can take sample by either gastric aspirate or induced sputum. You can take. I told you how you will induce sputum. We can take the sample and we can send it for culture and the CBNet test or LPI, line probe assay. We can do LPI mainly. We don't do much because LPI do for drug sensitivity. First line drugs, rifampicin, second line drugs like quinolone and streptomycin, injectable, so we check with LPA. LPA don't use much for diagnosis. So early morning gastric aspirate I have told, CBNet already I have told, line probe assay. First line LPA resistance to rifampicin and isoniazid, second line LPA resistance to fluoroquinolone and second line injectables. Second line injectables you use. What are the injectables you use? Then tuberculin test, indirect indirect infection, tuberculin test. Now we use usually nowadays 2 units of tuberculin PPD for RT23. We give, then we see after 72 hours in duration. In duration is more than 10 is positive. If positive baby means he had some infection of TB or he is having TB. Either of these two possibilities there. Now a baby with tuberculin positive with suggestive of findings. Suggestive findings means having cough, he is having loss of weight, loss of appetite, not gaining weight, all these things, history of contact, anything is there. Then we can suspect or it may be a probable TB. I told you, still in pediatrics we are using it. Confirmed TB, if my bacteriology confirm it. If you cannot do bacteriology, you can have probable TB or suspect TB. So here, tuberculin test will help you to suspect whether he has some evidence of infection of tuberculosis in his ear. There. If 5 to 10, borderline. In immunocompromised case, we sometimes we take 5, more than 5 as a positive. We give treatment. Less than 5 is negative. Why TB? Because some other mycobacteria infection also can give tuberculosis test positive. Even BCG can give you tuberculosis positive. Now BCG will not give a tuberculosis positive report more than 10. That's why more than 10 always you take it as a positive. Nowadays we do another new is this TB. Another test has come, skin test. TB. Here instead of using PPD, they are using ESET66 and then there is CPF or CFP10 they are using. Their hypersensitivity is less than the tuberculin. CI test, CI TB, this they are doing. Newer, it is also our national program has accepted this. Some states are doing this. Then extra chest, another indirect evidence, not microbiological, but indirect evidence. Like if you can see miliary TB, you will get the miliary micronodular cytos, intrathoracic lymphadenopathy, I told you already. Then there is a cavity. Cavity usually we don't see in very young children, little at adult, 8-9 years boy, you may get cavity. This is the miliary. See, here is the big miliary shadows. Miliary shadows is there. Miliary shadows are there. Here, you are seeing one gland is there, plus some pneumonitis is there. Heterogeneous pneumonitis. Heterogeneous, not homogeneous. Then another is IGRA. Nowadays, IGRA also another done. This interferon gamma release assay. There is also indirect evidence. There is serum test, antigen antibody reaction they are seeing. But IGRA, now, we are not accepting nowadays. There are two types. One is TB spot and TB quantiferon gold. Because it is seen that in zinc deficiency, IGRA test is negative. Our country and most of the countries, children are zinc deficient. So that's why IGRA we don't accept. Now India government has banned this test, IGRA. We are doing only the IGRA and Mantoux test, they are equally effective. Same result they are giving. So that's why you don't do CTB, I told already. ESR is supportive evidence, is not important. Extra-Pulmonary TB, suppose it's a TB lymph node, then we go for biopsy or FNAC. If abdominal TB, we can go CACT abdomen to see the nodes are there or not, thickening of omentum is there or not, ileocecal mass is there or not, all these things we can see, abdominal CT. Or TBM, first examination is CSF. I told you CSF में physical, we see in pyogenic meningitis it should be turbid due to pus cell. Here it is not so turbid, but if you keep, you will get cobweb. You can do biochemical test, you can do bacteriological test, and MRI brain, CACT and MRI brain. This same 2-year-old child has clinically diagnosed TB. What is next? Next is treatment. Treatment, if it is our CBNet has given the diagnosis that it is a rifampicin sensitive, then we will go for first line drug. First line drug here, we give this 2 months HRZE and 4 months HRE. HRZE, this is the dose I have given. 8 pyridoxine, 10 milligram per day. Why you are using pyridoxine? Why? Because isoniazid can cause pyridoxine deficiency. That's why always we give pyridoxine. Steroid is not much indicated except TBM, addition disease, pericarditis, uveitis, and sometimes miliary TB. Use steroid. Otherwise, you don't use steroid. 2 weeks time we give steroid, then we taper about another 2 weeks. We taper the dose. Now, if it is a resistant or suppose susceptibility pattern is not known, susceptibility pattern is not known. In this scenario, Government of India has given 2 regimes. One is this first line, another is second regime they have given for failure or relapse cases. That they are using 5 drugs. Instead of 2HZE, we use streptomycin injection. For 2 months you give streptomycin, then 1 month HRZE, then 5 months HRE. It's total 8 months. Here 6 months is 8 months. That is the second line treatment Government of India has approved for children. Now another is DOTS. In adult we are using, now it is practiced in pediatrics also we are giving DOTS, but it is seen that daily regime is better than the DOTS. Means thrice in a week dose course. Then follow up, whether there is improvement in clinical symptoms or not. Now we are giving initial treatment, we are giving this year. Then we should follow up with if there is improvement or not. That is the most important thing we should see. Because nowadays multi-drug resistant TB has come. Suppose child is still symptomatic in spite of 2 months of treatment and intensive phase. And there is no setting for drug resistance. If there is no setting for drug resistance, like contact with, it is a relapse, or contact with some drug failure is, or if there is no setting for drug resistance, we can increase the intensive phase 1 more month. If there is setting for drug resistance or contact with TB, we should do the sample again, sampling, and we will start the second line, means 5 drug regime. Instead of 4 HRZE, we use streptomycin, we will start. That time it is 8 months. And if it is, what are the settings for multi-drug resistant? MDR. MDR, multi-drug and XDR already told. MDR and XDR. XDR means if it is a rifampicin isoniazid plus fluoroquinolone or 1 injection, means is resistant. Then is the XDR. Now, if it is a multi-drug resistant, then we should go for, there is no regime. We choose, suppose multi-drug resistant case, setting means if a baby is having past 1 year he had TB, but again there is relapse, or he has contact with any multi-drug resistant case, or he has contact with a person who has failure or who has died of TB, or he has not improved his signs and symptoms, we can suspect he is having multi-drug resistance. For confirmation, we should do for culture again. For multi-drug regime, we use some drugs. If other than these drugs, we use injectables. Injectables we use, you can use amikacin, capromycin you can use quinolone group of drugs, moxifloxacin, levofloxacin, ofloxacin, but moxifloxacin is not used much in children. We use mainly levofloxacin. We can use some bacteriostatic drug like PAS, ethionamide we can use. Nowadays newer drug has come, belanimide or belequin they are used in pediatrics, but pediatrics only belanimide is used after 6 years of age. Belequin still not recommended in pediatrics. Then if this drug, we make a combination, 5 to 6 drugs. We continue for 18 to 24 months. Thank you.
So after diagnosis, treatment, case presentations, we will be discussing about epidemiology, prevention and program. So we will be covering this under this headings: introduction, epidemiology, prevention, programs and references. So introduction. So what is TB? It's an infectious disease caused by, as you already know, it's Mycobacterium tuberculosis. So it primarily affects lungs. So what do we call it? We call it pulmonary tuberculosis. So which it can affect other tissues as well. As already sir said, eyes, bones, etc., sinuses. So what do we call it? Extra-Pulmonary tuberculosis. It can affect any part of the body, like GI system, like ileal and spleen, kidney, etc. Anything it can affect, like brain, which is called TB meningitis. So this is called extra-pulmonary tuberculosis, and it's an infectious disease. Still, it is chronic because it has long latent period. So if a person, they have like good cell-mediated immunity, so it won't affect them. It's a worldwide public health problem. TB is one of the amongst top 10 causes of death worldwide. So epidemiology. Whenever anyone tells about epidemiology, you have to think about 3 things. For any disease, either it is non-communicable or communicable. You have to put it one formula. This is epidemiological triad. What do you call? agent, host, environment. So for TB, what is the host factors? Right. Agent, it is Mycobacterium tuberculosis, which is like genus Mycobacterium. It is rod-shaped and it's an obligate aerobes. It grows only on oxygen. So it's a facultative intracellular pathogen. It's gram-positive, acid-fast bacilli. It multiplies slowly and it can remain dormant for decades. Like already I have said, it has long latent period. So what is the host factors? Host means us, like human beings, the host factors. So who can get TB? Like if any person goes to the in front of TB patient, it's not like that you will get infected with the TB. So for what do you need to have TB? So the main point is cell-mediated immunity. Everyone will not get TB. So if your cell-mediated immunity is good, you will not get affected with the TB. As we are vaccinated with BCG vaccines, we all have tubercle bacilli in our body. Like they are injecting live vaccines to our body. So it will not easy to get infected with the TB. You can have TB infection, but it will not manifest, which is TB disease. So age, it can affect all the age group, especially 12 to 24 years of age group. Sex, it's more common in males. Why males? Because they are going like outside, outdoor work, they are doing more outdoor work, but the fatality is more with the females as compared to the males. So nutrition is malnutrition predisposes to the infection, which is widely prevalent in developing countries like India. So why? You have to understand why nutrition. So it's a vicious cycle. So poverty means they will not have food, so malnutrition, which is specifically undernutrition. This undernutrition, your cell-mediated immunity will go down. So if cell-mediated immunity will go down, you will get infected. If infected, again you have to like spend money for the disease. So again it will can cause, this is a vicious cycle. Poverty, malnutrition, infection and so immunocompromised groups, which weakens immune system like HIV, person on immunosuppressants, lifestyle, smoking, alcohol. Again, what smoking causes? It predisposes tuberculosis. Environmental factors, which I already have told you, lower socio-economic status. So again, poverty. As it is called, it's a disease of poor people. Tuberculosis. You will not see easily rich people will get infected with the TB if there is no history. For example, healthcare workers, they can have the TB. But if you go to some area, you can see n number of people who are infected with the tuberculosis bacilli. So it's crowded living conditions. Again, so like overcrowding, poverty, substandard housing, all this migration again overcrowding. Hospital healthcare workers who are directly in contact with the like patients of tuberculosis. So prevention, how will you prevent? You just have to know the factors. You can easily, you don't have to remember also how will you prevent it. You can easily, so first like agent factors. What will you do? BCG vaccination. BCG, Bacillus calmette-guerin vaccine. Then early detection and treatment. How will you do early detection? Like for grassroots level healthcare workers, like ASHA worker. So like doctors will not go to the house to house, door to door visits. ASHAs will be the contact point for them, first contact point. So there is like 4 golden rule. So 2 weeks of cough, then fever, which is evening rise of temperature, followed by your hemoptysis, unexplained weight loss. Like what they will complain? They will complain against like they don't have like
Like I used to wear like dress, now it's not fitting us. So this way you can detect early. And treatment, prompt treatment. If we can detect, we can easily. Then contact investigation. The perfect word is contact tracing. The exact word is contact tracing. And then infection control. How will you do the infection control? Health hygiene, hand hygiene, and cough etiquette. Like mask, wearing mask, you have to maintain. And then screening and treatment for the high risk groups. What are the high risk groups? As I already told you, like for example, who doesn't have good cell mediated immunity, poor people who are living in the slum, like household contacts of the tuberculosis patient. So screening for high risk groups, migrants, and then improve living conditions. For example, substandard housing, like one house, 10 people are living, one room, there is no margin only. So you can do improve living condition. How you can improve the living condition? By again poverty alleviation. So like the government is providing various like Antodaya, BPL, like public distribution systems. And then IEC and BCC. IEC means information, education and communication. BCC means behavioral change communication. So how will you inform them? Who will inform? You will not go directly house to house. Ashas they will come in contact. If I go also randomly, they will not come. We are not that much approachable to the community. There will be various cultural, social, language, every barrier. So they will come to the context. We have to tell the Ashas. So they will inform them like cough etiquette and then like hand hygiene, like if household contacts, to take medications, stigma, like people don't want to come up with the TB. It's a stigma. Like if someone is having TB, the society will separate them from like full the society. So they will not allow like from some one well is in like one village. They will not allow them to take the water from there. They will like discretion and behavioral change communication. Like take medicines, wear masks and all. So BCG vaccination. So what is that? It induces benign artificial primary infection. Cause what? Why it is like inducing artificial primary infection? For after birth, this is the within 15 days, as early as possible, you have to vaccinate the children, child. So how will you do that primary infection? They are inducing live vaccines. So the strain is Danish 1331. This is a NEET PG question. Like every alternate year it comes this question. And it's the vaccine can be liquid as well as freeze dried, which is more stable. This freeze dried vaccine, like these are the types of vaccines. It's not like that the vaccine, like different vaccines, same vaccine, the strain is different. It is like once is freeze dried, once is liquid. The dose, if there is, for example, if they are like hospital, for example, Santiniketan hospital, they are coming. So they will vaccinate on the day only. Like within 24 hours, they will vaccinate. So what will be the dose? It will be 0.05 ml. Manlo, like if it is any periphery or like at a home, they delivered the child and they don't know anything about it. Then Asha came after 15 days. They went to the house for the visitation, whether the child is good or not. Then that time they said that like there is no vaccination. So what? That time the dose will be 0.1 ml. If it is more than 4 weeks, it's 1 month. Then the route, it is intradermal. So there will be ulceration after the vaccination. So you will be knowing whether the child is vaccinated or not by knowing the that induration. You will see we all have that vaccination. If no one is if anyone is having, it is not there. So that means they are not vaccinated with the BCG. And the side effects are severe ulceration. Like if it is like dose miscalculation or something, if any hypersensitive reaction, lymphadenitis, osteomyelitis, disseminated infections. So the effect, which is 80% effect, will go up in 20 years. If the child is 20 years, then the effect will not go. But by this time, the child, we will be adult, so we will developing the immunity, good immunity. So it prevents disseminated TB. That means tubercular meningitis, which is the fatal, which is the main cause for mortality among under 5 children because of TB. So now government came with the new initiative. which is adult TB vaccination. So who are the eligible for the adult TB vaccination? This group of people, individual with at least one episode of TB, who had one episode of TB in their lifetime, entire lifetime, and who are the with the poor cell-mediated immunity. That means decreased immunity. It is nothing but decreased immunity. Age more than equal to 60 years. BMI is less than 18 kg per meter square, which is again related to the undernutrition. See, poverty, malnutrition, infection, again poverty, this vicious cycle, and close contacts with the TB patients. Who are the close contacts with the TB patients? If I am having TB, so my family members will having the close contacts. They are the close contacts. If I am living in the slum, so my padosan and neighbors, they will be the close contacts with me. If I am coming, for example, I am teaching you, so you will be my close contacts. So close contacts will be the, and history of tobacco smoking and diabetes. Why diabetes? Again same thing, its cell-mediated immunity will be reduced because of diabetes. So then TB preventive therapy. So what is TB preventive therapy? So who are the target? PL-HIV, that means people living with HIV. Same thing, it's immunity. So if reduced less than 12 months with contact with active TB patient. For example, I am the TB patient, will be for 12 months, I don't know, but I am spreading the disease. So you close contacts of TB, then household contacts less than 5 years or above, other risk groups who are on immunosuppressive therapy, for example, anti-cancer drugs and dialysis or transplant patients. So what is the regime? 6 months daily isoniazid, 3 months weekly isoniazid or rifampicin if the person is more than 2 years. So what is TB preventive therapy? For whom? For all you will not give the TB preventive therapy. You will give the TB preventive therapy. So the concept is lying there. What is TB infection and what is TB disease, which I already have told you. So what is the TB with whom you will give? Who have the infection, not who have the disease. If I have the active disease, it will not work. You have to treat with the TB regime. That what is the 2-HRZE and 4-HRE. So TB preventive, I don't have the disease, but I am susceptible for the disease. So you have to give TB preventive therapy to me. So which is daily, 6 months daily isoniazid. Sometimes this is not feasible for the patient. So what they have done, other regimen, 3 months weekly isoniazid and rifampicin. If persons more than 2 years, less than 2 years, you cannot give this rifampicin. So because of that regime you cannot give to the under 2 years of children. So what are the contraindications of TB? So again, which I already have told you, active TB disease. Who have the disease, not TB infection. There are two terms. You have to keep in mind this. If you are not understanding this TB infection and TB disease, you will not be understanding what, with whom, what to be given. And acute or chronic hepatitis, hepatotoxic medications like nevirapine and alcohol consumption, signs and symptoms of peripheral neuropathy. Why these are the contraindications? Because what is the drug? This is isoniazid. If you know, sir will tell what are the side effects of isoniazid. These all are the side effects of isoniazid. You don't have to remember only. So this acute or chronic hepatitis, side effects, hepatotoxicity. This is a hepatotoxic drug. So acute and chronic hepatitis, you will not be giving isoniazid. Hepatotoxic medication, nevirapine. Where nevirapine we were using? AIDS. In AIDS. And AIDS, why were you thinking AIDS? Because PL-HIV, everything is interlinked. So PL-HIV, nevirapine we are using. So in that case, people living with HIV, we are giving this. So you have to change the regime. That HIV regime, anti-retroviral drugs, you have to change the drug. That nevirapine, you have to change to the other drug. If the patient is taking nevirapine, you have to change the nevirapine and you have to give the other drug. And hepatotoxic and alcohol consumption. Again it is hepatotoxic alcohol where it acts, the enzymes are in the liver. And signs and symptoms of peripheral neuropathy. So peripheral neuropathy, again what is the side effects of isoniazid? Peripheral neuropathy. So for that, what along with TPT you have to give 10 milligram per kg, change every 10 years. So what they have to do, every year 5 years they will plan. So 1962 to 1992, it was National Tuberculosis Control Program. What they are doing, they were like controlling, simply controlling whatever patient are coming, they will be treating, and it was and like failure, big failure. Then government thought we will come up with the RNTCP, Revised National Tuberculosis Control Program. Then 2012 to 2017, it was National Strategic Plan for TB Elimination. Same National Tuberculosis Control Program, only continuing with the improvisation of the drugs. And 2022, Government of India renamed this RNTCP as National Tuberculosis Elimination Program. Now the question is, why it is elimination and not eradication? Only one disease we have eradicated from the world, which is smallpox. Eradication means like complete tear out from the root. Like there is no that agent. If agent is there, you cannot eradicate. Extermination of the agent. And for elimination. So what is the elimination and what is eradication? Eradication means no agent. But elimination means agent is there, but I am stopping the transmission. I am interrupting the transmission. How you are interrupting? Same thing. What you are doing? Vaccination. This is the interruption. We are giving early diagnosis and treatment. This is the interruption. Cough etiquette. All these things we are. So RNTCP. What are the objectives? This is very important. Achievement of at least 85% cure rate. For example, for 100 patients, if I am giving 85% medications, 85% will get treated and they will be like free from TB. And augmentation of case finding activities. So, National Tuberculosis Elimination Program. Elimination means we are stopping the transmission. Formerly it was RNTCP. What are the strategies? Simple. What we will do? Early detection of TB. How will you do? Put smear microscopy, CBNet, all these things. Other modalities. Universal drug susceptibility testing. For whom? MDR-TB, XDR-TB. So you have to sensitivity testing you have to do. And free treatment for all TB patients. What this combination, fixed dose combination is come with the box which is free of cost. Government is providing. Private sector, wherever you go, they also have to ask from the government and take the medications and reduce TB mortalities. How? Same thing. So what are the key components of TB? Case detection. How will you do the case detection? It is of two types. Like I come to you or you come to the society. Like if I am in a village, you are coming to me, which is active case finding and passive case finding. What is active case finding? I am going. Actively I am doing. So it is active case finding. Passive means patient is coming to me. For example, hospital, patient is coming with the fever, cough, hemoptysis. So you have to do, sir, what is the problem, sir? Sir. Last third. So this is laboratory services. CBNet, microscopy 2, sputum smear microscopy 2. Then treatment, DOT strategy. Anyone can be the DOT provider. I can be any family member. Previously it has to be healthcare worker. Now government is saying anyone can be healthcare worker. Who is the will supervise. We will not ask patient to take medications alone. One person has to be there in front of the patient who is taking the medications. And then surveillance system like NICHI portal. Then diagnostic tool under NTP, same, sputum microscopy, CBNet, line professor. Government initiatives. This is NICHI portal. If you have time, 2 minutes you spend, you see the NICHI portal. It's so beautifully designed now, you will be mesmerized. All the notification case, every day, every second they are notifying. If if you check on 4 o'clock, you will be finding 5 o'clock, new cases are coming up. They will be notified. And NICHI Poshan Yojana, what is that? Same, I have already told you, poverty, malnutrition. So what government is doing? Poshan Yojana, financial incentive to the patient, 500 directly cash benefit to the patient, and it will directly go to the bank account of the patient. Then dots, then 99 dots, which is for the patient. Patient will give missed call at the like 99, like for example 100, 99, and they will be thinking, okay, patient has taken the medications. So this is 99 dots and active TB case finding campaign. Same active means going house to house. Asha worker, Anganwadi worker will go to house and survey. Then TB free village initiative, which is nothing but like we are promoting awareness, stigma. So after doing so many things, why we are not able to eliminate TB? Government has already told by 2025 we will eliminate TB. But still you go to Nikshay portal, how many cases are there? So you will be knowing, so that means why? What is the problem? These are the problem, drug resistance, whatever you do. We are reading drug resistance, like drug sensitive TB. But I have not seen like easy drug. If I say 10 cases of TB, 8 cases will be drug resistant TB and 2 cases will be drug sensitive TB. So it is very difficult to treat. And poor adherence. So for example, if it is drug sensitive TB, the duration is 6 months. For drug resistance, it can be go to till 9 to 12 months. XDR-TB like 24 months also. Still people are not able to we are able to cure. So poor adherence, like 18 months, it's very difficult to take and there are so many side effects. So patient don't take, they give up. And then social stigma. If one female, she is having TB, like the society will abandon that lady. And undernutrition, same, because India is a poor, poor socio-economic status country.
Excuse me, we have another speaker.
Yes. Thank you.
Okay, so overall we have broadly 2 classification of TB. One is the first line and one is the second line. Now that is the most important thing, because the patients what we have classified, as per has been discussed already, that drug sensitive TB and drug resistant TB. Okay. So in case of drug sensitive TB, all these first line drugs which has been shown here, that is isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. Okay, so these are the first line of drugs which are used in case of drug sensitive TB. Whenever we are considering drug resistant TB, any organism which is resistant to the first line of drugs, they are called as drug sensitive TB. Okay, so these are the drugs. These are the second line drugs. So you can see there is a big classification. So we'll be taking care of. Apart from this, there is another grouping of the drugs. The first group, this is also the first line oral drugs. Second group is the injectable drugs. Third group is all the fluoroquinolones. I hope fluoroquinolone will be discussed in the next TV classes. Group 3 is the fluoroquinolones. Group 4 is the oral second line drugs. Now, what is why you say that oral second line drugs? The drugs which are showing in group 1 plus streptomycin, they have low toxicity, means low ADR profile, and high efficacy. But due to the treatment and various factors, organisms get resistant to this. So then we have to go through in the group 4 and group 3 drugs. Group 4, actually one problem is that their side effect profile is bad. Actually, it's very, very bad. So we need to consider many things before giving this group 4 drugs. And there are group 5, which are the other groups of drugs which are reserved for the final section, like betaquilin, clarithromycin, clofazimine, linezolid, dilamanate, pretomanate, etc. So these are the drugs which has been newly introduced, and their efficacy has not been that much of confirmed, unlike the group 1 drugs. Okay, so let's coming into the one by one drugs. First drugs in the every regimen is the isoniazid. The code sign is H. Now all of us seen that we have showing that HRZE, HRE like that. So every drug has its code. Isoniazid, that is H. Okay, because the name is isonicotinic acid hydrazide. What is the mechanism? Like most of the drugs which is acting on the TB, they inhibit this. What is this? This is mycolic acid. This mycolic acid is specific to the tubercular organism. That's why this is actually acid first stick, just because of this mycolic acid. This is not present in any other bacterial organisms. So this group of drugs which are inhibiting the mycolic acid formation, they are acting only against the mycobacterium species, like Mycobacterium tuberculosis, Mycobacterium leprae, Mycobacterium avium complex, etc. Okay, this drug, now there are 2 types of drugs which we use in the regime. One is tuberculocidal, which directly kills the organism, and another one is tuberculostatic. What is that? That it prevents or stops the organism to multiply. Isoniazid is tuberculocidal and a very good tuberculocidal. Okay. And this is more active in the first multiplying organism. Okay, we will be discussing in the theory class. This is active against the extracellular as well as the intracellular, and in the acidic medium means at the necrose portion. What in the during the TB in the pathology will be discussed, I guess, that there is a caseous necrosis, and the caseous necrosis, this is in the environment is acidic. Most of the antibiotics what we give, they don't work in the acidic environment. Unlike isoniazid, it acts in the acidic environment. Mechanism already said, this inhibits the mycolic acid. Now there is also the resistance. Now 1 in every 1 million organism, there is an inherent resistance, which is not that significant until unless we are treating the patients with only isoniazid. So what will happen? All those organisms which are sensitive, they will be killed. But those organisms which are resistant means that one organism that will rapidly multiply, and it has been seen that in 3-4 months, all the organisms which are which are present in the diseased body, the taken over has been done by the resistant organisms. So that's why we have a multi-drug regimen. And another point is that mutation of the CAT-GG. Now in the isoniazid, it needs to be converted. It will be converted to an active metabolite, which is done by this CAT-GG gene. Apart from this, the mycolic acid formation is done by INHA and Cas-A. So the mutation of these genes prevents the conversion to the active metabolite plus binding to the mycolic acid. And these are the areas. The main area is the peripheral neuropathy for isoniazid. That's why we are adding pyridoxine. Now we will be coming to that. Then rifampicin. This is also a bactericidal drug, very much focused to that. It does not act on any other organism. What is the mechanism? Mechanism is that it also interrupts the RNA synthesis by, just remember this name, RPOB. INHA, Cas-A, RPOB. Don't mix up. What is the areas? Hepatitis. And this is very important. That comes the patient counseling. Whenever you are administering rifampicin to any patient, you have to say that your urine, your sweat, your tear, your saliva, everything will turn orange red. Now, why is this important? Suppose somebody is passing orange urine. What will be the first thought? Sorry? Orangey red color urine. What will be the first thought? Blood in the urine. Means hematuria. So we have to counsel the patient that don't worry, you are not having hematuria. You are having just this is the drug which is coming out from the urine. That's why the counseling portion is very important. Otherwise, patient will fear and he or she will stop coming to you. The doctor is given us such a drug which has given us hematuria. Okay, so be aware of it. Rifampicin, one more important is this is a very important enzyme inducer. You can see cytochrome P3A4, which is involved in the metabolism of most of the drugs. Then 2D6, 1A2, 2C. So now 2C is important because of acetylation. We have already discussed that, right? So there is lots of treatment changes and drug interaction need to be taken care of. Will be discussed later. Then comes pyrazinamide. The most important side effect is hepatotoxicity, and this is the only drug which is withdrawn from the after the intensive phase has been over. Okay. No continuation phase contains pyrazinamide. It's only given in the intensive phase. Side effect: dose-related hepatotoxicity, so liver disease, and pregnancy. Previously, before 2016, this drug was considered contraindicated, but nowadays various data is available, so that we are considering that after 2016, it is included in the RNT program now, which is known as NTP. Okay. Then ethambutol. Now, ethambutol, one important point is that you have to do fundoscopy before administering this drug. Why? Because this drug has a prominent side effect of optic neuritis, leading to optic neuritis. What it can lead? Blindness. Come on. Okay. So this you have to be take care of before initiating ethambutol. You have to do fundoscopy. Number one. Number two. In case of children under the age of 6 years, don't give it, because that kid won't be able to express that I am having problem in visual acuity. Okay. Streptomycin is an aminoglycoside. The mechanism is a little bit different. It binds with the 30S and 50S subunit of ribosome, so it prevents protein synthesis. Most important side effect is ototoxicity. So for that, what you need to do? You need to do conduction test. Okay. Now, what is the goal? First goal is to kill the organisms. Number 2, prevent emergence of resistance. Because even the shortest regime of antitubercular therapy is 6 months. So there's a big duration. So if you don't give multiple drugs and you keep on treating without any kind of observation, then there is definitely resistance is going on. And as previously discussed, there are lots of MDR cases are developing. Okay, so that's why all the regimes, they contain multiple drugs which targets multiple locations. So at least it will hit something. So remember, H means isoniazid and rifampicin are the most potent bactericidal agent against all populations. Pyrazinamide based on intracellular bacilli and those in inflamed sites and stale agent activity. That is the reason it is given during the intensive phase, because most inflammation is happening during the intensive phase only. Then after the continuation phase, we start assuming that the acute inflammatory stage has been over. Now we can continue with the treatment for eradication. Intensive phase is for reducing the mortality of the patient, to increase the killing of the organisms, and continuation phase is to sterilize the patient, means kill all the residuing organisms so that the relapse and the spreading of the disease does not happen. Now, TB treatment, intensive phase, 4 to 5 drugs. Nowadays, we don't give 5 drugs. Streptomycin is almost not been given nowadays. So we have 4 drugs for 2 months. Continuing on, continuation phase, 3 drugs to eradicate remaining bacilli for 4 months. Okay. Now, sensitivity to check by LCDC, liquid culture drug sensitivity test. This is done at around after 2 months when the intensive phase is gone. Then we take samples and we check for the organisms in culture, and we see that whether the organism is still sensitive or the organism has developed resistance. Classification, we have drug sensitive TB, we have multi-drug resistant TB, that is the most dangerous nowadays because the pathology is also very high in these cases. And nowadays one more criteria has been developed, XDR-TB, means this is resistance with the both rifampicin and isoniazid plus 1 fluoroquinolone and 1 second-line injectable drugs, that is kanamycin, capromycin or amikacin. So total 4 drugs resistance, this is XDR. Technically the treatment is almost impossible and the mortality rate is very, very high. So drug sensitive TB, we have give treatment with rifampicin, isoniazid and pyrazinamide ethambutyl for 2 months. Then we omit pyrazinamide for the next 4 months. And in between we have to take sputum, and also we need to take chest X-ray just to see that whether the patient is, the treatment is going on properly or not. MDR-TB, this is the treatment protocol. The total duration is 6 to 9 months. Why 6? Now the question is that why 6 to 9 months? See, initially there are total 6 drugs: kanamycin, levofloxacin, ethionamide, cycloserine, pyrazinamide, and ethambutyl. Okay. Now what happens here? After 2 months, we take a sputum. If the patient is positive, then we have to continue the treatment for 7 months. Then we will do the sputum test on 4th month. If it is still positive, then it has to be extended. Now, like this, the treatment, the intensive phase therapy in total is considered up to maximum of 9 months. Then we have to consider XDR. Okay. If the sputum comes negative, then after 3 to 4 months of the sputum negative, we can start with the continuation phase with 4 of these drugs like levofloxacin, ethionamide, cycloserine, and ethambutyl. We are omitting kanamycin or capromycin and pyrazinamide, like the drug sensitive TB. Okay, so these are the other cases.